The following podcast is part of a certified educational activity titled The Second Coming of Finite Therapy in CLL, Making Informed Treatment Decisions with Newer Time-Limited BTKi Combinations. Access the entire activity and complete the post-test at peerview.com/JWX860. Downloadable slides and practice aids are also available.
Good morning, everyone, and welcome to the Satellite Symposium from PeerView's The Second Coming of Finite Therapy in Chronic Lymphocytic Leukemia. I would like to welcome also my two co-panelists, Dr. Nicole Lamanna from New York City and Dr. Lydia Scarfo here from Milan. With that, I would like to shortly introduce to you again time-limited therapy in CLL, overview on current practice, and I would like to start here with the practice guidelines, with the ESMO guidelines, which have been published last year. They are currently being updated. Therefore, these guidelines do not yet include the recent approval, acalabrutinib plus venetoclax. In general, you can see the guidelines differentiate with respect to the risk profile for the patients, considering the lesion 17p or TP53 mutation on the right-hand side. So we do not yet have head-to-head comparisons in this patient population, or actually for all of them, with respect to the questions of time-limited treatment in general versus continuous treatment. When we look at subgroups of clinical studies and phase 2 studies, it seems that patients with this very high-risk profile of CLL benefit more from the continuous treatment. At least the progression-free survival is very long. In some of the phase 2 trials, there was even not a significant difference for patients with TP53 operations, but there were also other results showing again that even with targeted treatment and even with BTK inhibitors, in tendency relapses are coming early in these patients, and they may also have additional mutations when they're relapsing, as for example resistance mutations. Of course, also time-limited treatments are an option in those patients, and we'll discuss that later with one of the cases Nicole is presenting. But as we have seen in the CD14 trial, the relapses are coming earlier, and when patients are not treated adequately in relapse situation, this may also have an impact on the overall survival. When we look at patients with an unmutated IGHV status without deletion 17p TP53 mutation, the guidelines differentiate here between unfit and fit, or younger or older patients. And the reason for that is ibrutinib being mentioned here only for the fit patients in the first place due to the cardiac toxicities being observed with ibrutinib, and we will also come to that in head-to-head comparisons with higher rates of atrial fibrillation and hypertension. Therefore, ibrutinib in the elderly patients is mentioned as not among the first three priorities. What you also see that so patients have a higher risk or intermediate risk with unmutated IGHV status, time-limited treatments are mentioned in the guidelines as the first preferred option. And the reason for that is that we discussed that time being off treatment is a value for the patients, and the possibility receiving retreatment is also a value. And as long as we do not have the data from the CL17 trial, for example, which is a trial for a head-to-head comparison for ibrutinib versus ibrutinib venetoclax and venetoclax obinutuzumab, we do not really know which of these treatment options is really the best. On the left-hand side, patients with mutated IGHV status, they have a very favorable prognosis. These are the patients therefore that's the reason why FCR, the chemoimmunotherapy regimen, is still mentioned here. We know from a study from the MD Anderson Cancer Center that probably some of these patients are really cured. When we look at young patients with very favorable prognosis, and overall observation beyond 10 years or longer shows that there may be in a subgroup of patients with excellent responses, no more relapses being detected within 18 years. However, FCR is associated with a 5 to 8% risk of secondary MDS or AML, and that's the reason why it's mentioned here only in the last place. Due to the very excellent prognosis and data from the CL13 or CL13 Gaia or CL14 trial on venetoclax obinutuzumab, this is therefore mentioned in the first place, but followed by time-limited treatment in the young patients, ibrutinib, venetoclax, and then followed by the continuous treatment. A little bit more specified is a recommendation Stefan Stilgenbauer, Eugen Tausch, and Christoph Schneider presented at the ASH Educational last year on CLL, where they specified, again, a little bit more for patients with mutated IGHV status, really to favor, independent of age or fitness, using time-limited treatment and then using the continuous treatment. And for the unmutated, they saw there's a similar role for the continuous treatment. Then relapses may really indeed come earlier due to the faster proliferation of CLL when the IGHV status is unmutated, when time-limited treatment is used. And the recommendation here for the lesion 17p, a TP53 operation, was also similar first choice, where the continuous treatment either with acalabrutinib or zanubrutinib, and as you can see, acalabrutinib is here recommended as monotherapy, not the combination with obinutuzumab, because subgroup analysis have shown that patients with this high-risk profile probably do not benefit from the addition of obinutuzumab. The NCCN guidelines, finally, they were already recently updated, very recently, because they include already the venetoclax acalabrutinib regimen, so it's not yet officially approved by the FDA. In contrast to the ESMO guidelines, which are very much driven by grade of evidence and the phase 3 trials being reported, the NCCN guidelines are listing more a list of possibilities for the treatment and no prioritization of the different treatments. However, you can see also in the US, since ibrutinib, venetoclax is not approved, and also ibrutinib as monotherapy is less used. This is not among the top priorities for recommendation. So just to review again, the regulatory status is that, of course, all the BTK inhibitors are approved in frontline treatment, and now we have for acalabrutinib the extension for approval of acalabrutinib venetoclax with or without obinutuzumab antibody. And we have, in the relapse situation now, the first non-covalent BTK inhibitor approved, pirtobrutinib, which is approved after prior exposure with covalent BTK inhibitor. That means a second-line treatment, and venetoclax approved in combination or as monotherapy in patients with TP53 operation not being fit enough for BTK inhibitors. How does the reality look like when we look at now the use of the different regimens among patients? This is a study which was done in France, Italy, and the UK, a retrospective study where they obtained the data between October 22 and March 23. So probably how were patients treated before that time point. And you can see most of the patients received ibrutinib, and acalabrutinib was then the second frequently used BTK inhibitor. It differed between the countries. In the UK, more acalabrutinib, for example, was used than ibrutinib. But when we look at chemoimmunotherapies, we see that still FCR or also bendamustine rituximab was used in CLL patients in frontline, and venetoclax obinutuzumab was used less frequently. However, the study was done nearly 3 years ago, looking at the data retrospectively. Probably when we would look at the data today, they probably look different. So summarizing, our goals for today are that we improve your knowledge of the evidence supporting finite therapy with BTK inhibitor, BCL2 inhibitor options in treatment-naive CLL patients, since we have now 2 choices, and that we provide you with the skills you need to integrate time-limited targeted platforms into personalized upfront CLL management and help you to address practical aspects of care with these double oral combination regimens such as dosing, treatment planning, and safety management. And with that, I would like to hand over to Lydia Scarfo. Thank you.
Hi, good morning, everyone. I hope you enjoyed Milano city life, nightlife, but that you are ready to focus on management of patients with CLL this morning. Going back to our clinical cases, let's start with Gianni. As you have heard, he's a 60-year-old man with symptomatic treatment-naive CLL. He has only one, I would define, mild comorbidity, well-controlled hypertension. Before starting treatment, we tested immunoglobulin genes, and they are unmutated. CLL cells are not carrying TP53 aberrations, and the reason for starting treatment is the presence of bulky lymph nodes, definitely more than 10 centimeters. So, Nicole, Barbara, I would like to discuss with you, how would you manage this patient? Time-limited therapy or continuous treatment? And in more detail, the reason here for progression is the presence of bulky lymph node. Does this change your approach to the patient?
An ideal. Can you all hear me? Okay, great. This is when I look at this patient, it's ideal he's young. And so a young patient, I'm always thinking about how do we get these folks off therapy? So a time-limited approach would be definitely something I would consider for this individual. He has well-controlled hypertension, so I do think that he's still fit for a BTK inhibitor. And even with his bulky disease, he's somebody that you can, give a combination therapy, do a BTK, debulk them, and still add a BCL2 inhibitor. He doesn't have high-risk features, although he is unmutated, but he doesn't have a deletion 17p or TP53. So I think this is an ideal candidate for a time-limited approach.
I agree with what Nicole said. I also definitely would use time-limited approach. I mean, the tricky thing maybe is here the bulky lymphadenopathy, because certainly when you start a BCL2 inhibitor, you have to monitor this patient really very closely. And so we have, of course, when we start with obinutuzumab, 3 infusions, and coming in with venetoclax, usually this is also the bulking regimen, but you really have to be careful with the first obinutuzumab infusion in this patient. And on the other hand, when you use, for example, Acala plus venetoclax, you have the 2 months of dosing in with the Acala, probably the lymphadenopathy is gone, or at least not gone, but decreased, and therefore maybe the risk for tumor lysis is a little bit less prominent.
I fully share your view, but I want to know more now. For example, Barbara, because Nicole from US doesn't have any experience probably with ibrutinib plus venetoclax. But what's your experience with the combination of ibrutinib plus venetoclax in terms of dosing and toxicity management?
Yeah, so with respect to dosing, usually when you start with a venetoclax dosing in, you really have to be careful with respect to neutropenia. Sometimes really check if you can escalate the dose to the 400 milligrams, sometimes give GCSF support, but usually after a while patients are tolerating the combination quite well.
So, and one of the pros is that if you start with the ibrutinib debulking at the time of venetoclax initiation, the TLS risk is generally decreased, so you can manage easily the ramp up, let's say. But Nicole, in US, I know you are more creative. So have you ever administered treatment with, a combination of venetoclax-based regimen following an MRD guided strategy?
Yes. I mean, obviously, I think, the role of MRD is something we're all still grappling with, or who, in terms of the length of treatment and what's the optimal duration of treatment. We are testing for MRD in our patients on time-limited approaches. I don't know how that, here in the EU, if that's done across the board. Obviously, our goal of thinking about time-limited approaches is really to get people off of therapy, because that's something that the goal of treatment is to get off of therapy. I think that whether or not they're, as you've seen, or maybe we're going to show some of this data, but there are many trials, and we're not showing everything today. The length of duration of treatment, depending upon the trial, MRD obviously can change, but also obviously then the length of treatment changes too. And some of these time-limited approaches may not be so time-limited, like if we talk about the UK FLAIR study, for example. So I think we're still sort of grappling with not only testing, and we could talk about a whole conversation about what is the appropriate MRD testing, right? So, is this 10 to the minus 4th, 10 to the minus 6, NGS testing, of course. And then what is the assessment in terms of we going to use that as guidance for keeping people on longer? And I think that's something we still need a lot more data on in randomized controlled trials.
Fully share your view. Last question about this case. What about retreatment with BTKi after I+V or BTKi?
Yeah, absolutely. I mean, I think we have, in this data, hopefully we'll go through some of this, is I do think that we have some good data from some studies that where folks from I+V who have required retreatment. And so there are some data suggesting certainly you could retreat with I, or you could treat with I+V again with encouraging data. And so I do think that with time-limited approaches, there's less resistance. And so the ability to retreat these individuals who come off therapy is encouraging so far. But of course, we need longer follow-up.
Thank you so much. So let's go to the next case, which is Stefania, a 71-year-old woman. Please note that we slightly changed the patient characteristics. So she's carrying 17p deletion and TP53 mutation. She has one, I would say, relevant comorbidity, the presence of atrial fibrillation that requires treatment with bisoprolol, a beta blocker, and edoxaban, and a novel direct anticoagulant. And the reason for starting treatment this time is the presence of anemia due to bone marrow infiltration. So again, taking into account the patient's characteristics, would you choose time-limited or continuous therapy? And because here I just say that the main point is that the patient is carrying TP53 aberrations, and guidelines, as Barbara just showed, are suggesting continuous treatment for this group of patients. And last but not least, this patient was diagnosed with atrial fibrillation. What about a similar patient without this comorbidity? Barbara, I don't know if you want to start first.
Yeah, I mean, without cardiac comorbidities, certainly I think continuous treatment with BTK inhibitors or clinical trials evaluating intensified treatment would be my first choice. But since the patient has a history of atrial fibrillation, she is on edoxaban, so we have to, with respect to the risk profile, relatively high risk. She's developing again atrial fibrillation, and that she may also have a bleeding event, and therefore in spite of the TP53 mutation, I would discuss with her time-limited treatment.
Nicole, any further thoughts on this?
Yeah, this is a tricky situation. The patient is older with comorbidities. If we're going to do a time-limited approach, I would do a second generation, of course. Versus ibrutinib, and getting her off of therapy might be beneficial. It's a little tricky because I think the doublets are still a little bit inadequate, and so the question is, would a triplet be a little bit of a better scenario? But the problem is she is older and she has comorbidities, and I do worry about the triplets in somebody who's older with many comorbidities. But I think, given some of the data that we'll share, it's something that is a consideration for high-risk individuals, our time-limited approaches, given that she, with a BTK, and we would normally, if she was not with AFib and on these concomitant medications, I think I would still recommend a continuous BTK approach. But it becomes a little bit more challenging with the comorbidities and her medications. I think you have to weigh the risk-benefit and talk about the potential side effects of each of these with her.
Thank you so much. So just to summarize, for the first case, the patient, the young, relatively fit patient carrying unmutated immunoglobulin genes without TP53 aberration, the panel would favor a combination of a BTK inhibitor with a BCL2 inhibitor, taking into account also the presence of bulky lymph nodes. While for Stefania, our second case, carrying TP53 aberration, there is more debate actually. So the guidelines suggest to use continuous BTKi treatment in this setting, but we are also taking into account that the presence of comorbidities and also patient preferences we didn't have the chance to discuss may play a role in choosing the best course of action in this patient. So I just want to focus a little more at this point with the data we have available about the combination of BTK inhibitors and BCL2 inhibitors. And I would like to start by underscoring that we have changed the goal of our treatment in the last few decades. So we have shifted from achieving symptoms control and improving the quality of life of our patient to aiming at curing CLL. We are not there yet. In the meantime, in the management of our patients, we have to take into account several pillars: the disease profile, TP53 aberration, immunoglobulin G mutation status, the patient profile, including age, comorbidity, organ function, the drug profile, drug-drug interaction, the profile of the adverse event, and of course, patient preferences are becoming crucial. So here you see that besides the genetic profile that is shown on the left, there are several other factors that play a role in our treatment decision. And actually, from a biomarker standpoint, provided that we avoid the use of chemoimmunotherapy, we are safe, meaning that we have very favorable results with several targeted agents, with the targeted agents currently available. So now we are fine-tuning our treatment choice based on other factors, treatment logistics, the adverse event profile, and in particular, of course, some specific comorbidities became crucial, like the cardiovascular comorbidities, the renal function, and taking into account that we are managing patients with CLL, who are by definition at decreased risk of infection, we want to reduce the risk of developing severe infection. According to the guidelines Barbara just showed, we are shifting from the use of continuous treatment to fixed duration treatment because the time-limited therapies have some greatest advantages. I would like to start by discussing the first fixed duration regimen the German CLL study group developed, so the combination of venetoclax plus obinutuzumab. Here you see the results of the CLL14 trial, where elderly or unfit patients were enrolled and randomized 1-to-1 to chlorambucil plus obinutuzumab or venetoclax plus obinutuzumab. Needless to say, venetoclax plus obinutuzumab was much more effective in achieving long-term disease control compared to chemoimmunotherapy. And recently, we have seen the results of the 6-year follow-up showing that the progression-free survival rate at 6 years was still more than 50%, 53%. And in addition to that, if we focus to time to next treatment, at 6 years, 65% of patients were still free from retreatment. In this study, they performed a further analysis, trying to identify factors associated with a shorter progression-free survival. And as you see on the right, the presence of TP53 aberration, of unmutated immunoglobulin genes, and bulky lymph node defined as 5 centimeters or higher were all associated with a shorter progression-free survival. The same combination was tested against the chemoimmunotherapy with FCR or BR in a younger fit population in CLL13 trials. Probably most of you have seen the updated results presented yesterday by Moritz Fürstenau. I just want to show you that also in the young fit patients where we have very intensive but also very effective chemoimmunotherapy regimen, the combination of venetoclax plus obinutuzumab was successful in achieving long-term disease control with a 4-year progression-free survival of more than 80%. And I don't want to discuss in more detail the triplets because Nicole will cover these, but there are also some initial hints suggesting that that could be a benefit with the triplet combination. On the other side, we have also to take into account that these regimens are associated with an increased risk of infection that is also confirmed in this randomized trial. In terms of safety, the greatest advantage of fixed duration regimen is that when the patient experiences adverse events, they are usually occurring during treatment administration. So as you can see in the CLL14 when they tested for adverse events occurring after the end of treatment, you see that basically they disappeared. So we have to stay strong during the treatment, but then in the end, the patient can enjoy treatment-free holiday, let's say. So starting from the combination of venetoclax plus anti-CD20, we were wondering if there are other potential partners that can synergize with the action of venetoclax. And here you see that there is a strong preclinical rationale in combining ibrutinib that has a strong effect on the CLL cells in the lymph nodes and mobilize them into the peripheral blood with venetoclax. And this combination is able to eliminate resting and dividing CLL cells. So this strong preclinical rationale led to the use of this combination in clinical trials. And on Sunday, you'll see the updated results of the Captivate study, where in the fixed duration cohort, ibrutinib plus venetoclax were administered for a total of 15 months in treatment-naive CLL. You see, this is a young patient population. The median age is 60 years. They are, of course, enriched of unfavorable disease features, and very reassuring results at 5.5 years of follow-up suggest that we consider the whole cohort. The PFS is still 66%. As you can see from the PFS curve on the left and in the table on the right, the most tricky population still remains the cohort of patients carrying TP53 aberration, because at 5.5 years, they have a progression-free survival of around 36%. In a previous analysis presented at the last ASH, the role of bulky lymph nodes 5 centimeters or more, was investigated in this Captivate study. And what they have shown is that actually the presence of enlarged lymph nodes does not impact the progression-free survival nor the overall survival in patients receiving the combination of ibrutinib plus venetoclax. Again, the combination of ibrutinib plus venetoclax was tested in the setting of elderly unfit patients. Here you see the results of the GLOW study, where more than 50% of patients were still free from progression at 66 months. But in a more relevant way, when we focused on time to next treatment, actually the time to next treatment was not achieved in the majority of patients, both carrying unmutated immunoglobulin genes or mutated immunoglobulin genes. On the other side, we have to take into account that the tolerability profile of this combination might be different in young fit patients compared to elderly unfit patients. And on the left, you see the occurrence of atrial fibrillation and infection in the GLOW study. In blue, the rate in patients treated with ibrutinib plus venetoclax. And for comparison, on the right, you see that the most frequent adverse event in the young fit patient population enrolled into the Captivate was actually milder, with neutropenia being the most frequent grade 3 or higher adverse event, and only few patients developing cardiovascular adverse event, only one sudden death. In the GLOW study, where elderly unfit patients were enrolled, if we focus on the deaths occurring during or after treatment, we see that in the ibrutinib plus venetoclax arm, there were 2 cardiac deaths and 2 sudden deaths during ibrutinib treatment. But when we analyze in more detail the patient characteristics, they were carrying a very heavy comorbidity burden. So probably this would be a patient population where you don't want to start, even consider starting treatment and administer the best supportive care. On Sunday, there is also a very interesting update of the results of the FLAIR trial. Barbara and Nicole mentioned the FLAIR trial is different from the other study I've shown you because it's based on an MRD-driven approach. So patients are receiving the combination of ibrutinib plus venetoclax, and once they achieve undetectable MRD, they continue with the same combination for the same time. So if they achieve undetectable MRD after 1 year, the total treatment duration would be 2 years, and so on, up to 6 years of treatment. So I was very impressed from the abstract, and I'm very much looking forward to the presentation on Sunday, because as you can see, the combination of ibrutinib plus venetoclax is better not only than FCR, we already knew that, but also it's improving the progression-free survival and the overall survival if compared to the ibrutinib. And this is the first time we have this type of data. So we have different treatment strategies and different fixed duration combinations, and no direct comparison so far, unfortunately. So we are very much looking forward to the results of the CLL-17 trial that is currently ongoing, but I heard that they achieved the progression events, so it will be probably presented in the next meetings. Because as you see, patients with untreated CLL, regardless of fitness status and regardless of biomarker profile, were randomized 1:1:1 to ibrutinib continuous treatment, the combination of venetoclax plus obinutuzumab, and the combination of ibrutinib plus venetoclax. And we hope that this study will provide us with some answers in terms of how to choose the best treatment strategy in each patient. So the last point I want to touch upon is the development of resistance, because we know that with continuous treatment, at the time of progression, patients are resistant to therapy by definition, and in many cases, the CLL cells carry BTKi mutation and or PLC gamma 2 mutations. And for a BCL2 inhibitor resistance, the mechanism is actually more complicated, but some cases will still carry BCL2 mutation or upregulation of other BCL2 proteins. So here are the results of the analysis. The German CLL study group and Eugen Tausch, first author, presented, where they analyzed the genetic feature of the CLL cell at the time of progression after venetoclax plus obinutuzumab. And as you can see, there was no clear clonal selection at the time of relapse. This is reassuring us that we can use again venetoclax-based combination, including venetoclax plus anti-CD20s, as is done in the REVENGE trial currently ongoing, in order to achieve again disease control. So no BCL2 mutation and no mutation in other members of the BCL2 family was identified. Same analysis was performed in patients progressing in the CAPTIVATE study, because as you know, in a relevant proportion of patients, between 50 and 80% based on the cohorts, we can identify the presence of BTK mutations in patients progressing on continuous BTKi. And here you see that at the time of relapse after fixed duration ibrutinib plus venetoclax, no mutation in BTK or PLC gamma 2 was identified in patients enrolled in the CAPTIVATE study. And indeed, when they required retreatment, the protocol allowed the investigator to treat again the patients either with ibrutinib alone as continuous treatment or with another course of 15 months of ibrutinib plus venetoclax. The majority of patients, as expected, achieved again a response to the treatment, around 80%. And now that we have a longer follow-up, about 2 years in patients who were retreated with ibrutinib and 15 months in those who were retreated with ibrutinib plus venetoclax, we can say that the disease control was lasting because the majority of patients at the 2-year time point was progression-free and still alive. And again, this will be updated on Sunday. Thank you so much. We are, of course, happy to discuss together if you have any questions. Thank you.
Thank you. I'm going to change the cases a little bit, and hopefully, again, this will generate some more discussion. And please put in questions. We're all excited to answer lots of questions, and we thought we'd have 100 by now. But please put in questions, and we can discuss cases and go through these as well. So we're going to look at cases such as Jonas. He's a 70-year-old man. He's treatment naive. His performance status is not as good. He has a history of hypertension and COPD. He's unmutated, but he is not high risk from a deletion 17p53 or complex karyotype, but he also has some bulky lymphadenopathy. And then we're contrasting that to a younger Jonas. So he's 60, he has less comorbidities, but he's still unmutated, but he does have a deletion 17p, a p53, and a complex karyotype, and some bulky lymphadenopathy. So a younger and an older Jonas are going to set the stage. So with a older Jonas, again, slightly more comorbidities, not too dissimilar to what Lydia presented earlier, but he doesn't have high-risk features in the sense of a deletion 17p, although he is unmutated. So is finite therapy an option for this older Jonas with some comorbidities here? And if so, what would be the preferred combination partner for venetoclax given his comorbidities? And does the current evidence support a second-generation BTK ven option? Lydia spoke a lot about ibrutinib. Barbara, you want to comment about this case a little bit?
Yeah, thank you very much, Nicole. I mean, certainly in this patient, following the ESMO guidance, I would also in the first place discuss with some time-limited treatment, venetoclax plus obinutuzumab, but as we learned from Lydia, the patients with bulky lymphadenopathy above 5 centimeters in the CL14 trial had a little inferior PFS rates. So therefore, I would also discuss with some time-limited with BTK inhibitor, BCL2 inhibitor, his comorbidity burden, and also considering his age, that for the GLOW study, patients above the age of 65 were included, where we had where we had more mortality during the treatment. I would, in this case, discuss with them venetoclax obinutuzumab or acalabrutinib venetoclax.
Yes, I agree. First of all, I'd say that I would wait until the lymph nodes achieve 10 centimeters or higher in my clinical practice, because I have to admit this is what I generally do. But then, provided that the patient is progressing and requiring treatment, I would do my best to find a way to administer him a fixed duration regimen. So probably here is the patient that would benefit of a multidisciplinary approach. I would involve the cardiologist, the pneumologist, in order to improve the comorbidity status, and then discuss what are the available options, and also in terms of patient preferences and logistics, because I understand that probably the combination of venetoclax plus obinutuzumab is less impactful on his comorbidity profile, but it might be not feasible in real life, for example, because the patient is living far from the hospital and doesn't want to come to receive the IV infusion or the frequent testing of venetoclax. So I would consider a BTK inhibitor, BCL2 inhibitor option in this patient. Which one, we don't know, but probably we can find a way to define a combination that is better tolerated in this relatively fit patient, and I would say also relatively young, so he's more than 65.
And then again, similar to what you presented earlier with regards to retreatment, any different discussion regarding retreatment?
Yes, retreatment is certainly a very relevant topic, because, I mean, a 70-year-old today still has a very significant life expectancy of 15 years around, maybe, and therefore for him the question is also, what relapse treatment options do I have after receiving the frontline treatment? And many patients are anxious when they receive already the double oral combination of both classes of drugs, which are highly effective, BTK inhibitor plus BCL2 inhibitor, that they want to know how high is my chance that I respond again to these treatments. And to be honest, I think the data here are still very scarce. I mean, the 11 patients from the Captivate trial, where we have more specific data, and we have some real-world data, but I think this is a really gap of knowledge.
Yeah, fair.
Yes, I agree, but I think this is the typical situation where we will gain more information in clinical practice than based on what we get from clinical trial, because unfortunately the follow-up of clinical trial is very short in this regard. But now we started using the combination of I plus V, the patients treated with venetoclax plus obinutuzumab years ago are now relapsing. So we will learn, I'd say, probably from clinical practice more than from clinical trials. But I think that the preliminary data from the Captivate are reassuring, because we have the biological rationale behind them, and it's confirmed in the clinical practice. So, as Barbara mentioned, it's a bunch of patients, so it's very difficult to draw solid conclusions.
Agreed. And just moving on to the younger Jonas. So now, again, he's 10 years younger, so he's going to have more time. No relevant comorbidities, but he's high risk. He's unmutated, and he has a deletion 17p, p53, and a complex karyotype, and moderate bulky adenopathy. So now a younger patient, would continuous or time-limited therapy be appropriate in this gentleman who's younger and has all of these high-risk biomarkers? Barbara, you want to comment?
Yeah, I think in this case, really a clinical trial would be my first preference, however possible, because when we use, for example, triplet combinations, or we could, of course, now discuss also using a triplet combination in that patient, then because we have to consider when we use now the continuous treatment, we know these patients have a higher chance of developing resistance mutation when they carry TP53 operation. And unfortunately, these patients with CLL still have an impaired life expectancy. Though, so the ESMO guidelines recommend continuous treatment. Considering his age, I would really intensively discuss with him the alternative option of a triplet regimen. We will hear later from you about that. Having longer treatment-free intervals, are trying to avoid resistance mutations. And I mean, of course, maybe he would still in 7-8 years be young and fit enough for undergoing allogeneic stem cell transplantation, what was the practice we used to do in the past in these patients. But certainly we would like to avoid this type of treatment.
Yes, I totally agree. I just say that the key point here is the presence of TP53 aberration. I'm still puzzled how to use the information on complex karyotype, because in the ESMO guidelines is not included. I know the German guidelines focus more on these, but I just say that the high-risk profile is defined by the presence of TP53 aberration. And I agree that in a young patient, I think it's worth discussing also time-limited options because we want to allow him a long treatment-free period.
Okay. So just for the summary for this, I think for the older Jonah, we talked a little bit about second-generation time-limited approaches. We're going to go over this because Lydia focused a lot more on the ibrutinib-venetoclax combination. Obviously, I'm going to be doing much more of the second generation and the triplet combinations for the setting of these cases. So we really think that somebody who's older, has some comorbidities, but no deletion 17p or p53, you can do a time-limited approach with a second generation because of his comorbidities. For the younger Jonas with high-risk feature, of course, we always think about, again, high-risk features, chronic continuous therapy, particularly for older individuals. This would be ideal, right? 70, 75, 80, TP53, a chronic continuous BTK inhibitor would be ideal unless they have, brittle cardiac issues and we have to think differently. But certainly for the younger Jonas who's got these comorbidities and biomarkers that are high risk, perhaps a time-limited approach, knowing that if they were on chronic continuous therapy, they're ultimately going to develop some resistant mutations. How can we get them to extend their PFS and overall survival with a time-limited approach? So we're going to talk a little bit about triplets in this setting. Although triplets, I don't think, that you guys already have the approval now, or at least have AV plus or minus Obina. Is that correct?
Yeah.
It's on? Yeah. Okay. We don't have that yet in the U.S. We're waiting due to the Amplify data for this. It is on the NCCN guidelines, but it is not yet currently FDA approved. And I think, obviously, with triplets, we'll talk about, this is certainly, in my view, probably an ideal candidate for a triplet, although, again, we have to consider toxicity as well. So as you all know from the different BTK inhibitors, now that we have 3 of the covalent BTK inhibitors approved, and we have, as Barbara alluded to, the first non-covalent BTK inhibitor with pirtobrutinib approved as well. Obviously, you've seen these slides before with sort of the kinase domains of the ones that are more obviously selective, had less off-target effects for a lot of the adverse events that we teach our patients about, the cardiac issues, the hypertension, arthralgias, bleeding, so on and so forth. And so we're going to focus more on the second generation. Here are the head-to-head studies, again, that many of you are familiar with. This is the ELEVATE-RR study that compared acalabrutinib to ibrutinib in the relapse refractory population. This was a slightly higher risk population, included patients with 11q and 17p. It met its primary endpoint of non-inferiority between acalabrutinib and ibrutinib. The median PFS was 38.4 months in both arms, but you can see there was a lower cumulative incidence of the adverse events of special interest, the atrial fibrillation and atrial flutter, hypertension, bleeding, diarrhea, and arthralgia. And so, again, for many of us, this was sort of a suggestion to sort of move away from ibrutinib. In the U.S., we've certainly moved away from ibrutinib for the second-generation BTK inhibitors due to the side effect profile. Here's also a relapse refractory study comparing zanubrutinib with ibrutinib in the Alpine study. A different patient population, so please try not to compare that to Elevate-RR. This was all comers, so not as high-risk patients, and less heavily pretreated. The median lines of prior therapy was 1 in this study compared to 2 from the Elevate-RR study. There was a PFS benefit demonstrated with zanubrutinib over ibrutinib in this study. There's a 36-month PFS was 64.5 months with zanubrutinib versus 54 months with ibrutinib. You could see from the side effect profile, the biggest difference between, at least in this head-to-head study, was the difference in the cardiac adverse events with zanubrutinib, with atrial fibrillation, atrial flutter, and less cardiac deaths with zanubrutinib and ibrutinib on this study. Similar adverse events with hypertension and hemorrhage were noted after 39 months of follow-up. Now, what about the Amplify? This is obviously the study that we've been talking a lot about. Here in the EU, you have ibrutinib and venetoclax. We have put this on the NCCN guidelines in the U.S. However, again, because it was our less preferred BTK inhibitor, it has not been adopted as everybody was waiting for this data. And so hopefully we too will soon have this FDA approved with acalabrutinib and venetoclax, although it is also currently on the NCCN guidelines. So here in the treatment-naive patient population, patients were randomized in a 1-to-1 fashion of acala and ven for up to a year, acala, ven, obi up to a year, or chemoimmunotherapy with FCR or BR for 6 cycles. Take note again that no patients with deletion 17p or p53 were allowed on this study because obviously there was a chemoimmunotherapy arm. And the primary endpoint here was PFS as assessed with AV versus chemoimmunotherapy. And the secondary endpoints were PFS of AVO versus chemo or AV versus chemo. So you could see the data here that was presented a little bit earlier, too, that the time-limited acalabrutinib and venetoclax, the primary endpoint was met. It significantly improved the PFS over chemoimmunotherapy. You obviously can see that for both the AV and the AVO arms, favoring that over chemoimmunotherapy. And you can see that the PFS was highest for AVO at 83% versus 77% with AV and versus 67% with chemoimmunotherapy. When you break that down by the mutational status, you can see it also favored the AV plus or minus obinutuzumab arms versus chemoimmunotherapy. And as Barbara alluded to earlier, we used to think about chemoimmunotherapy for your mutated, fit, younger patients, that was still a benefit for those individuals. And now we have, I think, several studies that have shown that even for those individuals, chemoimmunotherapy is not as beneficial as the sort of combination treatment. So both AV and AVO, even for the mutated, was still superior to chemoimmunotherapy. You could see that the mutated patients benefited whether they got AV or AVO. The PFS was similar for both, 86% for AV and 83% for AVO if you were mutated. But you could see what's benefited from the triplet combination were the unmutated patient population. So the patients who received AVO, the PFS was 83%, which was higher than even AV at 69%, or chemoimmunotherapy at 57%. So again, benefits for acalabrutinib and venetoclax plus or minus obinutuzumab over chemoimmunotherapy. There's also higher rates of undetectable measurable residual disease with the AVO triplet that you can see here. You can also see there's a fair amount of undetectable UMRD even in the chemoimmunotherapy arms, which we've seen even with our older data sets, and less so with the AV combination. This, of course, keep in mind, was 10 to the minus 4th. Again, we talked about earlier that there's different levels and depths of detection 10 to the minus 4, 10 to the minus 6, NGS, and so on. Hopefully, over time, we'll all get on the same platforms about how to test for MRD, and that'll be consistent across trials and practice. It's going to be a little bit more challenging in the U.S., I think, than I fear over here, but we'll look for more data on that. And there's an updated presentation by Paolo Gia here tonight, the poster presentation, so please check that out. Looking at the updated undetectable minimal residual disease, again showing that AVO led to the deepest remissions with regards to MRD negativity compared to chemoimmunotherapy or the patients who received AV. Now, what about the safety summary? And remember, this was published, so please take a look at the full publication online. But certainly, we always think about the toxicities of these combinations with our patients, particularly because many of them are older and have comorbid conditions. You can see here that infectious complications were highest in the AV-AVO arms compared to even chemoimmunotherapy. There was more neutropenia with AVO and chemoimmunotherapy, likely due to the addition of the monoclonal antibody to those regimens. You can see very little in the way of tumor lysis, more so in the chemoimmunotherapy compared to AV or AVO. Relatively little AFib, actually, in all arms. Maybe a little bit more in AVO, but again, relatively little across the board, and hypertension, relatively little, maybe slightly higher in the BTK-containing arms compared to chemoimmunotherapy. You can see the SAEs in total at the bottom. Remember, the infectious complications that got presented, of course, had to do with COVID. There was also COVID-related deaths during the time period of this study, and there were more COVID-related deaths in the AVO and chemoimmunotherapy arms compared to AV. So keep that data in mind as well. Now, we're all looking forward to this study. So again, looking at the doublets with the, again, second-generation BTK inhibitors, acalabrutinib and venetoclax versus venetoclax and obinutuzumab in the treatment-naive setting. And the patients are randomized. This is closed to accrual now, so we're waiting for the data to be presented once they have their first events. And so patients, what's interesting, obviously, is this is comparing it to standard of care with venetoclax obinutuzumab for a doublet. But also, it's a little bit MRD guided, right? So patients can, if they have detectable MRD at about the 1 year, 12-month, 14-month arm, because there's a 2-cycle lead-in with the acalabrutinib in the AV arm, if they are MRD positive, they can go on to receive another 12 months of AV or another 12 months of venetoclax. All patients will discontinue therapy at 24 months, and then they'll continue the follow-up. So we're looking, this is obviously an exciting study because we're looking at it because it compares it to another doublet, but also there's also an MRD portion with this study, and so I think that's an important part of the study. Obviously, there are other BTK and BCL2 combinations. There are different BCL2 that are a little bit more, perhaps more selective than venetoclax that are being evaluated. One is sonrotoclax. There's also data for lisafticlax. And this is a study looking at sonrotoclax and zanubrutinib in the untreated patient population. Patients are randomized to either get zanubrutinib and sonrotoclax with a zanubrutinib lead-in versus venetoclax and obinutuzumab as standard of care, and the primary endpoint is PFS. And certainly they're also looking at undetectable rates of MRD in the bone marrow and peripheral blood and overall survival, et cetera. This is a little bit of some data with zanubrutinib and venetoclax. So this is not a completely time-limited approach. This is Arm D, which included patients who had either deletion 17p or p53, but also there were patients without deletion 17p or p53. For the high-risk individuals on the right, you can see that patients had a very high overall response, about 99%, with a lot of an increased frequency of complete responses, about 46%, in about 66 patients with high-risk disease. Now, this particular, I'm showing this data because we don't have as much data on the combinations with zanubrutinib. This particular Arm D, though, was zanubrutinib and venetoclax, but followed by continuous zanubrutinib maintenance therapy. So this is not truly a time-limited approach, but it is some data that we do have on zanubrutinib and venetoclax in combination. Barbara and Lydia both presented a little bit data about the Gaia CLL study, and I'm presenting it again just to talk a little bit because of the triplets, because we're going to talk a little bit about triplet therapy. And so obviously this was in the upfront treatment naive population as well. And you can see here you have data with ibrutinib and venetoclax plus obinutuzumab versus obinutuzumab and venetoclax versus chemotherapy versus an arm that had venetoclax and rituximab. And you can see here that the PFS was still superior for the arms that had venetoclax and obinutuzumab, but certainly also seemed to be superior for the triplet at 81%, with ibrutinib, venetoclax, and obinutuzumab compared to the other arms. What about some of the second generation BTK inhibitors in triplet combination? And so this is some data from the Dana-Farber group. Matt Davids has presented this data looking at acalabrutinib, venetoclax, and obinutuzumab. And he had enriched for a higher risk patient population. Many of these had TP53, 17p, or complex karyotype. The majority were unmutated. And there's a high degree of efficacy in this triplet combination. You could see in 42% of the patients who had a TP53 aberration, they achieved their primary endpoint of complete response with undetectable UMRD in the bone marrow at the start of cycle 16. So you can see on the right-hand side, increasing cycles over time, the proportion of their responses continue to rise. And so this is very encouraging that in a high-risk patient population, the 4-year PFS and overall survival is 70% and 88% respectively in patients with a TP53 mutation. With regards to the safety of the AVO combination that Matt has presented, there obviously are increased adverse events with a triplet combination. You can see any grade, 99% had some sort of adverse event, and half the patients had, 56% had some adverse event that was grade greater than 3. So keep that in mind. Obviously, infectious complications of any grade were about 46%, higher than grade 3 were about 21%. You could see hypertension due to the BTK inhibitor and infusion-related reactions because of the obinutuzumab. Very rare bleeding events. You could still see some neoplasms, of course. Atrial fibrillation of any grade was about 6%. Some tumor lysis, but relatively mild, and no ventricular arrhythmias so far. So no ventricular arrhythmias, febrile neutropenia, or opportunistic infections or major bleeding events thus far on the AVO reported by their group. What about retreatment? And again, we talked about the fact that we have very limited data. The most data comes again from Captivate and some of the other ibrutinib venetoclax, because obviously that was the combination being looked at first, being ibrutinib was first to market. We'll get some more emerging data from AV and AVO. Matt presented this data recently at ASH, looking at 5 patients on AVO who required retreatment. The majority of the patients did respond. You could see here on the right. Except the first patient who had progressive disease, he discontinued due to Richter's transformation. But you could see the other patients, a PR, 2 CRs, and 1 that obviously sounds like they're responding because so far their duration of treatment is 38 weeks, but yet probably not yet formally evaluated at the time of the presentation. So at least 3, perhaps 4 of the 5 patients requiring retreatment have re-responded to retreatment with AV. Now, we're looking forward to this data from the CLL16 trial, looking at venetoclax obinutuzumab versus AVO, the triplet in high-risk CLL patients. So again, this is going to dovetail nicely when we talk about those patients where we're not quite sure, but would like to give a time-limited approach, and we're contemplating that in patients with high-risk disease. So patients will be stratified based on the deletion 17p or p53 and complex karyotype, and they'll, in a 2-to-1 fashion, be randomized to either venetoclax and obinutuzumab or AVO. And if they are MRD positive, in the AVO arm, they will be continuing acalabrutinib maintenance. Now, what about our data? Again, a little bit less because of the fact of the way these BTK inhibitors have been developed. So we have little but emerging data coming from zanubrutinib. Here is the bovine data with zanubrutinib, venetoclax, and obinutuzumab. This was also enriched for a high-risk patient population. There were 39 patients in the phase 2 study that has been presented previously by Jake Sumarai. Here, deletion 17p or p53 was 13%. The majority of patients were unmutated. The median follow-up so far about 40 months. And you can see the primary endpoint with the bovine combination was very high. 96% achieved an undetectable MRD in the peripheral blood and 92% in both the peripheral blood and the bone marrow. And you could see that on the right with the 5-year follow-up. So very encouraging data for higher risk patient populations so far, although again, short follow-up from some of our triplet combinations, but so far encouraging data for some of our high-risk patients. Here are the safety outcomes for the bovine. You can see the majority were grade 1, grade 2, with the majority being cytopenias, as well as diarrhea, bruising, cough, and infusion-related reactions. Grade 3 or 4 were mostly cytopenia issues with some diarrhea, and mostly cytopenias in terms of grade 4, grade 5. Now, when we talk about the BTK BCL2 combinations, whether you're using ibrutinib, venetoclax, or second generation acalabrutinib, zanubrutinib, venetoclax combinations, again, we alluded to the fact that even in patients with bulky disease, this is sort of an ideal regimen in the sense that obviously the logistics we talked about with venetoclax and obinutuzumab, whether you start with one agent or another agent, you still need to monitor those patients for tumor lysis. And with the venetoclax ramp-up, you're still doing the ramp-up accordingly, but still have to monitor for tumor lysis in those bulky individuals. With the BTK inhibitors in the combinations, you can front load, of course, the BTK inhibitors, whether 2 months or 3 month cycles, lead in, and then start the venetoclax. And usually the majority of those patients are debulked accordingly. I think a question comes up, and this is why we included this, about does the dosing change or is there a difference when you start the BTK lead-in? And no, we would still do the standard doses that you would do for each of the drugs, whether it's ibrutinib, acalabrutinib, or zanubrutinib, as your lead-in, and then you would still do the venetoclax ramp-up accordingly over 5 weeks. If you have somebody who's extremely bulky and you're still concerned after the 2 to 3 cycle lead-in, then you can certainly repeat their imaging prior to them starting the venetoclax ramp-up to see that if you're worried about whether or not they're going to be at increased risk at that point despite the 2 to 3 cycles lead-in, if you're going to be much more concerned with monitoring them as an outpatient. But the majority of patients are adequately debulked with 2 to 3 cycles of a BTK lead-in, so just to keep that in mind. Thank you.
Thank you very much, Nicole. You obviously convinced the audience about the role of triplet combinations. Maybe we start with a more general question from Dan. He's asking again, so how do we choose now between BTK inhibitor and anti-CD20 antibody or BTK inhibitor plus venetoclax? And also there is a general question, the comment that we should address this more clearly in the guidelines in the future, which patients should be considered for which combination. Not an easy task. Nicole, do you want to start?
Okay, which one do we go first?
CD20 antibody with BCL2 inhibitor or BTK inhibitor plus BCL2 inhibitor.
Yeah, I think that it is a challenging question. I mean, I think that hopefully from the randomized data, we'll see the difference between Ven antibody versus a BTK BCL2 combination. I think that randomized data will be very important. From a practical patient consideration, I think that, certainly there's no doubt, I think we've presented data that if you're a bulky disease, it's just easier logistically to do a BTK, BCL2 inhibitor-based combination. But I think there's still really good data for Ven antibody. It'll be nice to see the randomized data in the front line to see if one will, is better in the PFS, certainly from the combinations that will help us choose one over another in the frontline setting. But there's very compelling data that it certainly seems like the BTK BCL2 combinations have a high degree of efficacy. So,
yes, I totally agree with what Nicole just said. I mean, probably we should wait for the results of the CLL17 and the MAGIC trials in order to have more solid evidence to inform our choice. I would generally discuss the options with the patients and also try to understand, taking into account the benefit-risk ratio if the patient has any preference, and try to find, let's say, a common decision, to share a common decision. But I agree that the presence of lymph nodes is generally, bulky lymph nodes, is generally favoring the use of a debulking strategy with BTKi for logistics, and because we have some data suggesting that they do not have an impact in the long-term disease control with BTKi and BCL2.
But certainly you could say, well, what if you had a patient who has a ton of cardiac comorbidities and you don't want to use a BTK inhibitor, and so do I think venetoclax obinutuzumab is a fine option for that patient? Of course. So then you can look at, what are the comorbidities of your patients and then the side effects of each of the 2 different combinations, and also logistically talk about that with your patient as well.
Yeah, I agree. So I have to say, in the patients with mutated IGHV status, I still tend to give venetoclax plus CD20 antibody. We have very long follow-up data. We know maybe we have here a similar situation as we have it with chemoimmunotherapy, with FCR. Potentially some of the patients are being cured, but for the double combination, we are all looking very much forward to the FLAIR presentation on Sunday. Maybe the extension of the treatment could be another way to really cure CLL patients, and
Yeah, and I do think that's an important point. We talk about doublets and triplets, but, we sort of neglected the fact that some of these studies started as a 12-month, duration, time-limited approach, and then some of those, MD Anderson and other, some of those approaches extended. It became 12 months, then it became 16 months, then it became 24 months. So I do think we do need to take that into consideration, too, as we sort of look at these different trials and combinations, because I do think that impacts the PFS and UMRD rates and so on and so forth.
And for the mutated immunoglobulin genes mutated patients, I would also take into account that it's true venetoclax plus obinutuzumab is very effective, but still it might be, depending on the age, that we are administering only one line of treatment, and the combination of BTKi and BCL2i is much more convenient, being fully oral, so it has some pros, let's say.
Absolutely. It's very convenient for the patients, and there was also one of the questions, how long should the ideal lead-in of the BTK inhibitor be? Because with ibrutinib venetoclax we have 3 cycles, with Acala venetoclax we have 2 cycles. What is your experience with that?
I think the 3 months duration was still a quite arbitrary decision. I understood that was decided because of the redistribution lymphocytosis associated with ibrutinib that should decline at the 3-month time point. We have previous experiences where when the combination of ibrutinib plus venetoclax wasn't approved, and some patients paid for adding venetoclax because they were already taking ibrutinib, and we can see very impressive results after a longer debulking period of around 12 months. Of course, is off label, and I am not suggesting to do that, but I would test in clinical trial, because it might be that if you start later the venetoclax or even the anti-CD20 monoclonal antibody, you can improve the depth of response.
Yeah, and I think I'm hoping some of these studies, when we're looking at MRD-guided approaches, that they will also help us see about these length of durations, with the combinations, because that might sway us in our differences of extending between, let's say, even the mutated and unmutated, in that sense.
So there are 2 questions with respect to the cardiac risks with the BTK inhibitors. So one of them is, what do you think with respect to ventricular arrhythmia with acalabrutinib? Probably the question is referring to the Ohio State data in their respective analysis on ventricular arrhythmia. Nicole, you want to comment?
So there's no doubt. I think that, regardless of the BTK inhibitors that are chosen, overall, I think the data is still suggesting that there's a more favorable cardiac profile with the second generations, even though there was some data that Barbara's alluding to that did show there were some arrhythmias, ventricular arrhythmias. And so, we still teach our patients, we should still be teaching our patients about all this, regardless of the BTK chosen. But I still think the data is still more favorable for the second generations, given the head-to-head studies and others. And so I would still prefer them over ibrutinib in that scenario.
Yeah, maybe Lydia, the other question is, do we think this is a class effect of the BTK inhibitors, also considering the non-covalent BTK inhibitors, which have a different mode of action but still affecting the BTK protein?
I just say that for non-covalent BTK inhibitor, the data is still scanty because we have shorter follow-up, and so far we have not seen a high rate of atrial fibrillation or even bleeding events with pirtobrutinib, that is the one that is currently approved, but I would wait for longer follow-up before drawing definitive conclusion on this. I'd say that the cardiovascular adverse events are part of the class effect of BTK inhibitors. With ibrutinib, at least part of them is related with the off-target effect, so they are reduced, as we have seen with the second-generation covalent BTK inhibitor, but still they are not without any risk of cardiovascular adverse events. But in terms of continuous treatment, I'm shifting from first generation to second generation continuous BTKi when used as a monotherapy.
Mm-hmm. There are two questions with respect to relapse treatment, in particular after venetoclax plus acalabrutinib. What would be the first choice here? Would you rather, so not yet officially approved, go again for a double oral combination, or would you prefer to switch to venetoclax plus approved is only rituximab, but some give also obinutuzumab?
Yeah, I think partly also I would, my decision would be also in part, is there any change in the patient's biomarkers? So I would retest and see if that was a patient who didn't have a 17p or p53, did they acquire that now with the combination? Hopefully not, given the data that we've seen with the time-limited approaches. But, you know, if there was a change in their profile, I might decide to, if I was going to retreat, then do maybe continuous therapy. I would certainly like to put that patient on a clinical trial. But yes, I would think about, rather than maybe a time-limited approach again for that patient if they've acquired high-risk features at that point. So I would retest before making a decision, I think, with regards to what to retreat, whether it be time-limited again versus continuous monotherapy or something else.
For me, it depends also on the duration of response after fixed duration treatment. I totally agree with Nicole. The biomarker profile is key because, what allows us to stop treatment is the venetoclax part, because we know that with BTK inhibitors we should continue treatment because we do not achieve undetectable MRD, let's say. So if the patient relapses, and luckily enough this happens very rarely after a few months after the end of the combined treatment, I would probably go for a continuous BTKi, while longer response duration would allow me, in an ideal world where all the options are available, to re-administer the same treatment. And this is actually the rationale of using time-limited therapy, because otherwise we know that with continuous BTKi, and now we have 10 years of follow-up with ibrutinib, we can achieve long-lasting disease control, but the patients still pay it all in terms of toxicity and then develop resistance.
And probably similar to the way we look at Ven/Obi too, right? So when we think about retreatment with Ven/Obi, short duration's probably not enough, you know, with retreatment in that sense. But if somebody bought years off of therapy, then we'd reconsider. And again, relook at their biomarker profile.
Yeah, I agree with you. So in the practice, still continuous treatment is used a lot. Of course, it's very easy to handle. Therefore, there's a little provocative question. Is the time of continuous treatment over in CLL?
No. Well, I hope I'm not like the only I'll hide under the table. You know, I still think continuous therapy for some individuals is really appropriate. There may be other logistic reasons or lots of comorbidities, or I guess it gets harder to start stratifying patients in different ways. But let's say somebody is an older patient who really doesn't want to do a time-limited approach, and taking a pill or 2 or 3 or 4, depending upon which agent they're taking, is okay. I think that it's still there's still a good option for chronic continuous therapy. I think when we think younger, anybody who wants a time-limited approach, we're going to think time-limited approaches. But I think there are some patients where continuous therapy, I think, is still appropriate. So I don't know if it's going to go away just yet.
Yeah, I have to admit I do have a more and more problem with the continuous treatment beyond 6 or 7 years. Patients are on the drug when the CLL is extremely well controlled, and so the question is, what are you still treating in case patients even have undetectable measurable?
Well, I think and I really gear that. I think not to say that an older person can't do time limited, but I really think a lot more time limited for younger. But if you're 80 and want to do it continuous. That's, I think, the patient population I'm still thinking about if they want to, even though I don't think an 80-year-old couldn't do a time limit, I think, but I'm just saying those are the ones where I'm thinking still continuous might still play a role.
I agree, but even in an 80-year-old, I'm not sure if you need to give him the drug for 5 or 6 years. Maybe it's enough if he is for 2, 3, 4 years or for a limited time. On this treatment, because obviously symptom control, improvement of the physical status is the main aim, and not achieving undetectable MRD as in the young fit patients. Lydia?
Yeah, I agree. There were clinical trials trying to understand if we can stop continuous treatment and then restart once the disease progressed. We have an indirect evidence because we have patients who stopped because of intolerance and they remained in remission for 2 years or more. So I just say there is still room definitely for continuous treatment, but the better management, I mean, it's one of the reasons we are trying to shift to time-limited therapy.
There are 2 questions regarding endpoints in clinical trials. So we facing the problem, the luxury problem now. It's really hard to obtain OS data, to observe differences in OS. One question was, we talk a lot about PFS data. Can you please summarize the studies which really showed also difference in the overall survival? Maybe you, Nicole, and then the question to Lydia, MRD is a surrogate parameter for OS or for PFS even, yeah.
Yeah, I mean, obviously, you've seen a lot of the trial. I mean, obviously, the shift has been that we've been looking at PFS for most of these studies, given that trying to get OS out of these studies is much more difficult and requires a lot more time. But it is true that, you know, it isn't, it's not a perfect marker. I think many of us try to think about, you know, their time to their subsequent line of therapy would be a good idea as well, their second PFS or time to next treatment. But this is what we have. When you throw in MRD data, maybe I should segue that way, it gets more complicated because you can see even well, maybe I'll just let you handle as I switch over.
No, thank you.
Yeah, because otherwise
No, but I totally agree, and in line with what you were just mentioning, I think that the MRD is more complex than it seems, meaning that probably we don't need to reach undetectable MRD in all patients, and it's different based on the biomarker profile and also probably the type of treatment. So the majority of data we gather so far derived from chemoimmunotherapy combination, and this is where MRD was approved also by EMA as intermediate endpoint in clinical trial because it was proven to be related with progression-free survival. But then nowadays we know that, for example, in patients with mutated immunoglobulin genes, we can achieve long-lasting disease control even though we are not reaching undetectable MRD. So probably if we aim at MRD, we are over-treating this category of patients, while still for patients carrying unmutated immunoglobulin genes, they do much better if they achieve undetectable MRD, but have a different growth rate. So it might be that based on the biomarker profile, we should tailor also treatment duration and intensify treatment.
And so that's exactly where it gets muddied, and that's why I stopped saying what I was saying, because I really do think that, you know, we're going to get more specific about your profile, about their profile, and how to hone in which treatment might be better, because you've seen just from the data we showed, some people may have very chemoimmunotherapy at high levels of undetectable MRD in these studies, but yet you could see the PFS was shorter. So I think we need to keep that in mind. And so the ones who are favorable probably don't need as much, and the ones who are less favorable might be intensified treatment may be the way to go.
Yeah, so in those younger patients, our goal may be to achieve undetectable MRD with the frontline. There's a question, what do you think how the time-limited fixed duration therapies can achieve this goal, and how can we keep patients free of disease? Probably also, should we consider retreating and at MRD relapses, as in CML, for example?
Yeah, that's a good question. I think that, you know, it's hard, you know, right now we haven't been advocating, of course, for retreatment early for patients just who, based on MRD levels, if we know that their MRD level is rising, because we've known even from other treatments, even chemoimmunotherapy regimens, there are many patients with even forget MRD, just having evidence of obvious disease, that they could still be monitored for a long period of time. So I think until we have a little bit more data, although I think that's an important question, whether or not we should retreat patients earlier, depending upon MRD, I just don't think we're there yet. So we wouldn't advocate doing that off trial. I think we need a lot more work to sort of figure that out, if we should be retreating certain subgroups maybe earlier. I don't think this is going to be a one-size-fits-all, because I think there are patients who have favorable disease who probably may have disease, but can be monitored for years, and you wouldn't want to necessarily retreat them if it wasn't necessary.
Yeah, I completely agree. MID is a very interesting subject, but I would not test that in patients as well outside clinical trials. Okay, with that, I would like to thank you, Nicole, and Lydia very much, and thank you very much to the audience also for all your questions. We are sorry we couldn't address all of your questions. We hope you find the symposium helpful. Enjoy the meeting and Milan. Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board of Accreditation in Hematology. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/JWX860.